You actually just woke up and decided you wanted to get a plastic surgery consultation for your breasts, even though you may not have considered it before. In the ideal world, do you want to be bigger, smaller, or the same? I really like having the person responsible for removing the cancer separate from me, because they're going to do their best possible job. They don't care about me. They don't need to care about me. They're going to take out the cancer, and my job is to fix what I'm left with. There's two camps when it comes to breast reconstruction. I can use tissue expanders and breast implants, or I can use your own tissue. And in certain situations, we bring those together for what we call a hybrid reconstruction. Don't push your surgeon to do something that they're not comfortable with. If your plastic surgeon is saying, I don't really do that, I don't recommend it for you, pushing them to do something is a bad idea. So these are such unique and specialized conversations. And that's why, you gotta love your team. You gotta love each doctor in your team. And I think a lot of time the discussion and the conversations come as an avalanche because you get the cancer and you're just like, get it out, get it out. And you kind of just go to where you're sent, right? But the reality is you can only pick your Avengers team. You can pick each superhero in your squad. And if you don't like somebody, you can find somebody else. There's no rule that it has to be the same group of people.
Hi, I'm Bisma, and you're listening to The Other C Word, a podcast about all things cancer from a stage 4 breast cancer warrior. We cover health and wellness, mind, body, and soul. Plan to leave each episode with hopefully some new insights and inspiration. Let's get into this week's episode. Hey everyone, welcome back. Today I'm super excited to have Dr. Dhivya Srinivasa on the pod with us. She's a double board certified plastic surgeon and she specializes in breast reconstruction. And she's also got a ton of experience helping women feel like themselves after surgery. Dr. Srinivasa uses a mix of tried and true methods along with the latest technologies to make sure her patients get the care that's just right for them. What I love from her work that I've seen is that it's a very patient-centric approach, and so it's very individualized to the patients. Dr. Divya, thank you so much for being here.
Thank you so much for this opportunity. I'm really excited.
Awesome. Thank you. So what I was thinking of doing today is a little bit different from a traditional podcast guest. I was thinking we could do a little call it role play, so kind of like a mock consultation.
Yeah, absolutely. Absolutely.
That sound good? Okay, perfect.
That sounds great.
Okay, so let's say I come in as one of your patients or potential patients, and I've had a biopsy done. There's a tumor in my breast, and I'm working with my oncologist to see whether we'll do a lumpectomy or a mastectomy. And I want to kind of pull you into the conversation now and to see, what your role would be. So maybe we could talk through what my options are essentially.
Yeah, and I think actually it's important to bring your plastic surgeon into the conversation early if you can. A lot of people don't, and even the other doctors don't because they're like, that's plastic surgery. But the reality is the decisions that you make with your other doctors on lumpectomy versus mastectomy, because you may be a candidate for both, right? And you're making a choice on which one you want to go forward with. That decision may be impacted by what sort of reconstructive outcome you can have. And I'll give you an example. Not every lumpectomy is the same. If you have double D breasts and they want to take out a couple of centimeters of tissue, no big deal. We can do that with a breast reduction, with a breast lift, you'll be fine. But what if you're like an A cup breast or a small B and you have a larger tumor and they want to do a big lumpectomy, and they may use other terms like partial mastectomy, segmental mastectomy. Well, that's a big part of the breast, and that can actually look really deforming, especially after radiation. So if you were to go to that woman and say, okay, but if you have a mastectomy instead, it will be less deforming and look better, and you can avoid radiation. What do you want? A lot of women might actually choose mastectomy instead of lumpectomy, but they don't know, they're not given the whole picture. And no one, I don't want to say no one, but most people are not going to intentionally mislead a woman, right? But they're kind of tunnel visioning their approach to you. I'm an oncologist. I'm going to tell you lumpectomy and mastectomy are the same, and they're going to give you all the data. Or I'm a breast surgeon, and I'm going to say, this is the incision I would use for this, is the incision I would use for that. But in plastic surgery, I can tell you, girl, that's going to be hard to make look good, and this I can make look great. And that aesthetic consideration might actually affect your decisions. So the first thing I would say is think about your breast. How big is it? And how much tissue are they taking out? And if it's a lot, then you may want to consider a mastectomy for the reconstructive result. Say you have big breasts and they're doing a relatively small lumpectomy, then you should always ask your plastic surgeon if they can do a breast reduction or a breast lift at the same time, because that can help camouflage the defect or the hole that we leave behind. And when you get radiated, they're going to boost the area of the cancer. They're going to boost with extra radiation where that hole is, which is only going to make the tightness and contracture worse where you already have a defect. So being able to rearrange tissue and kind of fill in that hole will also mitigate some of the deforming changes you can see with radiation. So that's decision number one. Do you want a lumpectomy or do you want a mastectomy? So I try to talk to them through, again, individualized. Every woman has different breasts, and they're also like, I'm small breasted, but I'm a small person. So petite women can have large breasts, larger women can have smaller breasts, larger women can have larger breasts. Like there's so much out there as far as your BMI and where you carry your weight. Some women carry their weight more in their stomach or their thighs or their chest. So you got to be individualized. Otherwise, you're not doing a good job for your patient. So you want to look at your body and your body type. And I always ask if you could, like, if it's like the Men in Black memory stick and I could erase your memory and we're not here to talk about breast cancer, and you actually just woke up and decided you wanted to get a plastic surgery consultation for your breasts, even though you may not have considered it before, in the ideal world, do you want to be bigger, smaller, or the same? And I always use that line. And I want to know what their goals are because that can also help me navigate the conversation.
Okay.
There's only so many changes I can make with a lumpectomy and a mastectomy depending on what their goals are.
That makes a lot of sense. Couple of questions. So, what are the different people involved? So, obviously, the oncologist I've already met with, but so there's a breast surgeon and then there's a plastic surgeon. Those are two different people.
Yeah. So in some instances there are surgeons that do both. They've trained in both. I trained in both actually, but I choose to do plastic surgery. My personal opinion is that I think it does introduce a possible conflict of interest. I really like having the person responsible for removing the cancer separate from me because they're going to do their best possible job. They don't care about me. They don't need to care about me. They're going to take out the cancer, and my job is to fix what I'm left with. But there are some paradigms where it might be the same surgeon, although it's uncommon. And then there's a radiation oncologist. There's a doctor if you need radiation, and you may also separately have a radiologist, a doctor who's reading the MRIs and ultrasounds and mammograms. And then there's a pathologist, and that doctor is looking at the tissue under the microscope. So you've got all these doctors lined up, and they're all responsible for working as a team to make sure that we direct the patient in the right direction. Number one goal being cure the cancer today. Number two goal being make sure it doesn't come back. And then number three goal being instilling the best possible quality of life into the plan as possible. So
Okay.
I'm the quality of life pillar.
I like that. That makes a lot of sense. And then what about like, are the surgeries separate? So does the breast surgeon take out the cancer first and then we do a separate surgery with
It
you? Or
depends. In most situations, we do something called immediate reconstruction, doing it at the same time. So the woman wakes up. There are some rare situations, like if the tumor is so big that it's invaded the skin, we worry about margins. That's a term that we use for did we cut out the whole thing or did we leave little cells behind? We don't want to leave cells behind if we can help it. So, in certain situations where it gets tricky, I have had the breast surgeon request that they take the tumor out first, get the final pathology report, and then we proceed with reconstruction. But I'd say like 95% of the time, I'm doing it at the same time as either the lumpectomy or the mastectomy.
okay. Okay, perfect. Okay, so let's say I've decided on, which route I'm going, lumpectomy versus mastectomy. Um, what are my options for the reconstruction? Like I've heard about this thing called deep flap, and then I've heard about implants. Can you walk us through like the difference between those?
Yeah, so lumpectomy is a different category. If we're talking about just mastectomy reconstruction, the spiel that I would give in a consult, and if any patients listening to this, they're gonna be like, "Yeah, that's what she says," is there's two camps when it comes to breast reconstruction. I can use tissue expanders and breast implants, or I can use your own tissue. And in certain situations, we bring those together for what we call a hybrid reconstruction. So if I'm going to use implants, my preference is to go direct to implant. So I don't like to put in a tissue expander if I don't have to, because I like to remove that from the patient experience. It's uncomfortable. It requires a lot of visits for injections and fills. I don't like to use them if I don't have to. And I work with such good breast surgeons that I usually don't have to. I put in one tissue expander recently, and that was like the first one in 3 years. So I can usually go direct to implant. Direct to implant is a unique skill set. Don't push your surgeon to do something that they're not comfortable with. If your plastic surgeon is saying, I don't really do that, I don't recommend it for you, pushing them to do something is a bad idea. Find a surgeon who's really good at it and already does it and is comfortable doing it and ask them to do it. So I do a lot of DTI, direct to implant. I always go above the muscle. I think it looks better, feels better. There's risks and benefits to everything, right? So it's not perfect. I do think you can see rippling in the implant a little bit more, but I usually combat that with liposuction and fat grafting. So that's one camp. The other camp is using your own tissue, and that's where you get the deep flaps or lap, PAP, SGAP, IGAP, all these acronyms stand for where the tissue comes from. And where the tissue comes from is dependent on two things. One is your surgeon, a really, really good microsurgeon that's comfortable with doing all these flaps. A lot of them, the majority of them, only do deep flaps. But if you have a surgeon who can do a whole variety of them, you want to make sure you have that. And then the second one is, where do you carry your weight? Are you someone who happens to carry it in your tummy or your love handle or your thigh? And we can make accommodations based on that. And if you are not going to need radiation, then generally speaking, you're a good candidate for either or. If you need radiation or have had radiation, flaps are generally a superior option to implants. The times we would bring them together as a hybrid would be if someone doesn't have enough tissue to be the size that they want. Say I can make them a B cup with their D flap, but they want to with their deep flap, but they want to be a D cup. Well, I might add a small implant to the flaps. So they kind of get the best of both. They get the natural tissue, they get the tummy tuck, but they also get the volume that they're looking for.
Okay. Okay. Got it. What's the difference between, you said above the muscle versus below the muscle? Like what's the aesthetic difference, or and then what's also like the medical difference between that?
Yeah, so above the muscle we call prepectoral, and your pectoralis muscle is like a fan-shaped muscle, kind of butt sides like this. They start in your breastbone and they insert up here. So that muscle can be elevated and an implant can be slipped underneath it. And a lot of people in the cosmetic world still do that. And in breast cancer reconstruction, a lot of people do that. Well, as we've gotten really savvy with mastectomies, and our mastectomy surgeons are able to do these small hidden incision mastectomies and save the nipple and save all the skin, we don't really need that muscle there, because what happens with time is that muscle pulls up and out, up and out, up and out, and it pushes the implant down and out, down and out. And you'll find this implant just kind of moves away from the cleavage, which is, you want it near the cleavage. That's where you want the fullness. And it starts moving towards the underarm area and it drops, it bottoms out. So aesthetically, to be able to keep it above the muscle is more anatomic. That's where your breast sits. Your breast doesn't sit underneath your pec muscle, it sits above it. The downside, though, is that your skin is carrying the entire weight of the implant, which is why I personally will add a mesh called Galaflex, but different surgeons use different meshes. Alloderm is another option to help support the implant. And the other thing you would do is do fat grafting and liposuction, inject fat, because now you have less in between the implant and the skin. Instead of the muscle being there to kind of camouflage some of that rippling, you just have skin. So injecting fat and bulking up that layer can help camouflage the rippling as well. You can go under the muscle. I just don't do it because long-term aesthetically, I don't think the result is appropriate.
Okay. Was that like an older technique that people were
Yeah.
doing before? Okay. Okay. That
Yeah.
makes sense. Um, okay. This is a lot of good information. Okay. You mentioned nipple sparing. Can you tell me more about that?
Yeah, whenever safe, we can save your nipple. I would say one of the most common things that I hear in clinic is that women will say, I was told I'm not a nipple sparing candidate. And if you've been told that, I urge you to ask the question, why? What about my case means that you can't save the nipple? Because 9 times out of 10, if not more, it's because it's too hard. It's not because it's unsafe. The real reason to not save the nipple is if the cancer is too closer in the nipple. Then we can't save it. It's not a safe cancer operation, but that's pretty darn uncommon. Most of the time, it's because a woman has a large breast, or what we call a ptotic breast, meaning it's sagged. And it's hard, and they worry about the blood flow to the nipple. But in the hands of experts, you can very much accommodate for that. I can, for example, do a lumpectomy with your surgeon, combine that with a breast lift. You still get the cancer out, you get the lift. And then before you would need radiation for a lumpectomy, we hop in there, do a mastectomy with like a precursor procedure to optimize blood flow called a nipple delay. And I can save your nipple and I can do the reconstruction and you still don't need radiation. So now we're talking about really nuanced niche approaches to breast reconstruction, but it is nuanced and niche. That's why I hate hearing from people that the worst is when it's already been done. They said, oh, I didn't know I could have done that. Nobody gave me that option. They just told me I had to remove it and I can't bring it back. I can reconstruct a nipple, but I can't bring back the one they had. So that's always heartbreaking because it's sort of misguided decision making, right? We don't want that. We want informed and shared decision making.
Yeah. That makes so the benefit of keeping the nipple is like, is it because you can continue to feel the sensation? Is it less painful, like less recovery time? Why would I want to keep my original nipple other than just the fact that it's original there?
So sensation's a tricky topic. We can definitely talk about it. There are procedures these days where we can optimize and restore sensation to the nipple. It's never going to feel exactly the same after a mastectomy, so I don't want to set up false expectations, but we can definitely move the needle a lot on how much sensation is retained. It's because the nipple is the focal point of the breast, right? People pay attention to where the nipple and the areola is. Is one higher? Is one lower? Are they facing the right way? It
Right.
is the focal point of the breast. So to be missing that, I think aesthetically um, can be unfortunate if we had the opportunity to save it.
Okay. Okay. Got it. So I mean, do you know about, I mean, I've seen all sorts of pictures and videos of surgeries that don't look great. And that's, I think, to what you're saying, it's like the visual point of the nipple just doesn't look there. So it sounds like that's like a really important part of this.
I think so, because even when we have to remove it, we're talking about nipple reconstruction. I always tell all my patients it's the cherry on top. Don't rush into it. Make sure you're really happy with your reconstruction, because once you place the nipple, your eye is going to go to it. So make sure you're happy with everything else, because it's relative to that. So if you get the nipple tattoo and reconstruction done and then you do a lift, that's a little tricky, right? So you want to make sure you're already happy with the breast mound, the projection, the size, the location. And then last thing you should do is get a nipple reconstruction and tattoo.
Okay. Okay. Got it. Um, I think I'm still a little bit, so the fat grafting versus the implant. Um, I mean, it sounds like the fat grafting is kind of like killing two birds with one stone. Like you can, utilize your own tissue, which sounds like it's better for your body to have your own tissue versus a foreign object. What would make me want to go the implant route? Is it really just, as you said, like a bigger size, or is there another reason that I could consider?
So fat grafting is different from flaps. And I want to make that distinction very clear. A flap is a physical cut where we remove the tissue. It has blood vessels attached to it, and we sew those blood vessels back together in the chest so that the fat that I have transferred is alive and has blood flow. Fat grafting is distinctly different. That is liposuction with a long cannula, and you're moving that back and forth and you're pulling out fat. The fat is washed and prepared and re injected back into the body using a needle. So these are little small incisions.
Got
I
it.
think of fat grafting is like if uh, you're getting an ice cream on a hot summer day, right? Pick your flavor. Do you want to use your own tissue or do you want to use your implants? Fat grafting is like the sprinkles, right? Or it's what you're going to add to anything else that you've had done to make it better. So fat grafting can be done with flaps. I do it all the time. I'll do flaps and then I'll use the liposuction in her full capacity to sculpt out where I've already done the flap operation, usually the tummy or the thighs. And then I will fat graft onto the flap so that it's fuller or you get more cleavage or has more upper pole fullness. I can do the same thing with implants. I can do an implant reconstruction liposuction where you want me to, and then inject that fat back in. Fat grafting does not have an inherent blood supply. Flaps do, right? I'm sewing blood vessels together. That's why it's called microsurgery. I do it using a microscope. Fat grafting, any plastic surgeon can do. And you are expecting the host environment where you are injecting it to be healthy enough that it adopts the fat and grows blood vessels into it. That's why fat grafting will never have 100% take, right? They always talk about some of it melting away or dying off or forming little calcifications or fat necrosis. Now, you can get fat necrosis with the flap as well, but it usually means there was a blood supply issue in some capacity. And usually it's a small area, not a big deal. With fat grafting, it's less predictable. And again, it's dependent on that host environment. So if you have radiated, tight skin with a tight implant, that's not like a welcoming home for fat that has no blood flow. It's probably not going to do well. Fat from a flap, though, has its own blood supply. It's not depending on the host environment. So it is much more likely to thrive. And once you resurface that whole area, you can then fat graft into the healthy fat. So why would you choose one versus the other? I always say everyone's got what their goals are and what they're willing to go through. Flaps are an additional operation on the same day. So whether it's a tummy tuck or a thigh lift, we are operating on another part of the body other than just your chest. So in that case, implants are generally a shorter operation, although not always. And the risks of implants are infection or the implant needing to be extruded or removed or whatnot. An infection of an implant can be disastrous. It could mean that the implant has to come out and you're flat. With flaps can fail. The blood vessels can get clots. Those blood vessels we say together, but it's pretty darn uncommon. It's usually 2 to 3% of the time. Um, more likely the complication is something mild or minor and it doesn't leave you flat. So implants being easier, but I would say in the hands of a skilled expert, your overall chance of a lifelong successful reconstruction is higher with flaps. But I always say it's your investment in recovery and time for the long-term benefit. And not everybody's down for that right away. Sometimes you're like, I got too much going on. This took it out of me. Get the implant in. Let's move on.
Got it. Got it. Can we talk a little bit about the recovery process? Like, how does that vary from
Yeah.
surgery to surgery? And, if someone is going through, maybe chemo they did before, maybe they've got some coming up, like, how would I consider those things?
Sure. I do think that the recovery with flap surgery is harder in the short term, like the first couple of weeks after surgery. But whether I do implants or flaps, it's still 6 weeks of recovery. So the net recovery time is the same.
Okay.
But I would say that the like in the first 2, 3 weeks after surgery, I think flaps are harder to recover from. Um, chemo is gonna be chemo. I don't. It is unusual that I changed the reconstructive plan because I had chemo or need chemo. It's sort of I mean, it depends on who you work with, but I've had patients say, "Oh, I was told not to get flaps because I need chemo and I need to recover."
Mhm.
But my patients who get flaps recover just fine and get their chemo in the adjuvant or after surgery setting when needed. So again, I think that speaks to more of like the expertise of your surgeon. How in tune to your plan are they? Do they do this a lot? Can they get you where you need to be in time for your treatments? I would say radiation, it's controversial to do flaps ahead of time in the setting of radiation that you know is upcoming. I like to do it in most situations. I do make some microsurgical modifications. I will attach some extra blood vessels, but it is controversial and you should definitely, again, if it's something you want, and I've had patients fly out because they wanted it done at the same time and their surgeon back home told them no and they came out, they had it done, all was great, they got radiated, they move on, they're happy, but they've understood that you want to see an expert, you want to see someone who's doing this all the time, and everything is a risk benefit analysis. No one can promise you an outcome. So I'll do it and I'll say, hey, there's a chance this doesn't turn out so well because you have a wound or because of this, that, or the next thing, but my promise to you is I will get that fixed in time for you to get your radiation treatment.
Got it. Got it. So what if, I mean, as you're saying, it's a risk. So it sounds like there's a risk where, let's say I have a deep flap surgery and then um, down the line I need to have radiation. There could be, it could turn out not looking aesthetically that great afterwards. Is that right?
They're going to radiate the flap, right? Because you already had your reconstruction done. So it may not look great, but you don't know what the alternative is. You could have had an expander and an implant, and then it got infected, and now you're flat,
Right. Right.
right? Because that's the risk of an implant or an expander getting radiated. So I would say most of the time I'm comfortable doing it. The times where I tell them I'd rather not is if they don't have a lot of tissue, because then I don't have a lot to work with, and I'm a little bit nervous if I can really get them the result they're looking for. So if that's the case, I'll say, let me put in a direct to implant, get you through radiation. And then on the back end, 6 months later, that way every bit of tissue I put in there is fresh and it hasn't been radiated. So it has the best shot of surviving.
Okay. Okay, that makes sense. Have you seen a lot of situations where, people have surgery and they end up, the cancer's gone, but it ends up coming back, years later, and then you have to go back and do a revision surgery? Does that happen?
It's uncommon that the cancer comes back and we're doing revision because the cancer came back. It is very common that women are asking for revisions of their breast reconstruction because they're unhappy with the aesthetic outcome.
Okay. Okay, got it. And then is it less risky to do one surgery that's maybe a bigger surgery up front versus doing like subsequent surgeries over time?
We've done studies on this. Generally speaking, if you had radiation therapy, your long-term outcome is going to be better with the one and done flap. Implants are like tires on a car, for lack of a better analogy. And I use this analogy all the time. So I'm sorry if you've heard me on other podcasts, you've heard this before. But it's a really good analogy. Tires have a warranty. They're going to expire. Most people don't remember the exact date that their tire warranty expires. You kind of just drive your car until there's a problem. That's how breast implants are. They generally have a 10-year warranty, different based on different implant companies. But that doesn't mean that, like, ding, 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 when 10 years is up, you get your implants replaced. Some women will choose to do that. Some women will say, well, I feel fine, I look fine. And some women will say, this is miserable, I'm tight, I hurt, it doesn't look right, get it out. And they don't even make it the 10 years. So implants are a little unpredictable. Flaps are pretty predictable. Once they've done well, which you'll know in the first couple of days, that's your result for life in most cases. So I think in the setting of radiation, it's pretty clear that flaps are a superior choice long term. I think without radiation, the data definitely favors that flaps are a superior choice. But I have to tell you, I also have patients with implants that are perfectly happy with their implant reconstruction.
So I'm 37. Would your advice to me as a 30 something year old or 40 something year old differ if I was maybe like 50 or 60? Like, would you maybe, if I'm older, would you advise me to possibly go the implant route versus the flap, or does it
That's
not?
such a good question. That's a really good question. So, not all 50-year-olds are made the same. Not all. I had a 61-year-old in clinic today, and we're going to do her deep flaps. I've done deep flaps on 70-year-olds and even 80-year-olds.
Hmm.
It depends on how healthy you are, and it depends on what your goals are. So, if you are a healthy 80-year-old and you have 10 plus years left to live, deep flaps are a safe surgery. Takes me about 6 hours in an operating room to do both sides. You go home in a couple of days, you recover for 6 weeks. It is worth it. If you are an unhealthy 50-year-old with heart disease and a previous heart attack and stents, probably not a good idea for me to do flaps. So it really depends on each individual. I do like to be very open with my younger patients about, like, this is a long part of your life you have left to live with implants. It may be okay for you today, but maybe at 47 you come back and you go, okay, now I'm ready. Maybe at 57 you do an implant swap out and then you come back, right? So it's so individualized. You have to really figure out what's right. I have some women who are just busy moms. They got 3, 4 kids, and they're like, I just can't be down for, like, I have a 2-year-old. I need to get back to it. And we respect that. And they've come back when they're 2-year-olds and 4 or 5, and then they get the deep flap. So it really is, in most situations, there's no absolute one right answer. Radiation is the kind of the warning, the cautionary tale. I do think that there's generally a right answer in radiation. But without, in the absence of radiation, I would say all's fair game for most people.
Okay. Okay, that makes sense. You know what I'd really love to know is that, so I have metastatic disease, and the opinion that I've gotten so far from my oncologist is that once the cancer has spread, there's not necessarily a overall survival benefit of getting a mastectomy. But you hear mixed things about that. What is your opinion on that?
Okay, I have to give you the disclaimer that I am not a medical oncologist and I'm not a surgical oncologist, but I am board certified in general surgery and I am in the tumor board. I am, like, I'm part of it, right? So I hear all the opinions going back and forth. One, I think it does depend on the type of cancer that you have or had. And number two, there are studies that show a benefit from removing the primary site of tumor. And there are stage 4 patients that I have operated on. I just think it has to be a conversation. So I mean, I've heard horror stories from women, from my own patients that have come from all over the United States, and they'll say, my surgeon refused to do a mastectomy because she said I had stage 4 disease. And I am like, my mind is blown with that. In most situations, again, as long as we have good disease control, or you're no evidence of disease or stable disease, there is a role for removing the primary site of tumor. Um, but it really depends on your tumor biology and how you've responded to the treatment. So most women in the stage 4 camp have gotten a series of treatments, and we can compare the now to the then and kind of make an assessment of how good of a job our medications and treatments have done in treating the stage 4 disease. I have patients that are 17, 18, 19, 20 years out with metastatic stage 4 disease, and I honestly, cancer to them is like diabetes. Like, it's a thing that they have and they take medication for it every day, but it is
Right.
not affecting their quality of life. And I mean, our goal is to cure cancer, but on our way to that hilltop, we're getting really good about managing stage 4 cancer. And I think it's important to be reasonably hopeful. I think, obviously, you don't want to sell an untrue fairy tale, but a lot of stories for women are becoming fairy tales. And I think it's also nice to, like, share the positive stories. And I think it's nice. Part of that journey is going to be getting rid of your breast that caused the cancer, right? Like, how could it not be? So in most situations, I would say we still end up doing the mastectomy and are validated in doing so.
Yeah, that's really great to hear. I think a lot of people with metastatic disease, like, that's really important for them to hear, because I think there is still this general opinion of, like, once it's past the the presenting site that there's quote unquote no point. But I think there are differing opinions and different data sets on
Can
that.
I
So that's
curse?
really
That's bullshit. Like, yeah.
yeah,
I hate that because it's just not true, first of all. Like, we've gotten so good with certain treatment choices. I mean, HER2 positive disease has seen a story arc that is a fairy tale over the last 20 years. And
right.
what we're doing with triple negative these days, I mean, it's mind blowing. And we are seeing women live longer and longer and longer with this disease. And now we have decades of data in certain scenarios. And I think, like, I have patients where my general rule is 2 years now at evidence of disease and you're cleared by your oncologist. I'm happy to do your reconstruction. And I would say most women with stage 4 disease that is responding well to treatment absolutely should get their mastectomy if that's what they want.
Yeah, and you don't think they have to wait until it's no evidence of disease. They could do it if it's
It's
stable?
tricky. I can't give blanket statements like that, but I do. There are a lot of women that have stable disease. So one of the other terms we use would say like stable disease patterns. So sometimes you just have like a little lesion in your bone and it's always been there and it's always going to be there. And at some point we can't tell unless we biopsy, right? We get an MRI or we get a CT PET and maybe it doesn't light up anymore, but you still see the lesion. Was it a dead tumor or is it a live tumor? We don't really know. So I can't make a blanket statement that like, if you're stage 4, get your mastectomy. But I will
Right.
say that the majority of women with stage 4 that are getting adequate neoadjuvant therapies do qualify for a mastectomy.
Okay, that's great. And
And
that's
if you're not being told that, get a second opinion.
yeah, I totally agree. And you think that's it's in cases where someone's like hormone positive or triple negative, these are still conversations that they should be having.
I think if you are triple negative or HER2 positive, they're very, 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 very valid conversations to have. I think if you're strongly hormone positive and HER2 negative, it's just where has it spread to? Did it respond at all to chemotherapy? How much tissue? And here's the other thing is you get a lot of information from removing the tissue, right? If
Right.
you had cancer and then you remove the tissue, you know how well the chemo worked. And sometimes that can steer additional treatments after. So it is a specific conversation. And it's not a conversation as much with your plastic surgeon as it is with your oncologist and surgical oncologist. But doing a lot of this as I do, more women than not absolutely qualify for that mastectomy.
Okay. Okay, that makes sense. And I've also heard so when you um so when you have a surgery, obviously your body needs time to recover, so you may need to take time off of your continuous treatment. So whether you're on some sort of like hormone blockers or
Yep.
those medicines, what's your take on that?
So some medicines need to be stopped, some don't, right? I can usually do surgery through hormone blockers. Some of them have an increased risk of clotting. We can talk about it. Like Kadcyla, I like to stop. Every drug is a little bit different. So it's a conversation to have. And that's why most surgeons want to see that you've been stable disease or no evidence of disease for 2 years. So they feel comfortable taking a short pause on the medication to then do the surgery and start you right back on it. But again, has to be a decision made by the oncologist. So I've had patients who came in and I said, okay, well, let's wait 6 more months. You're at a year and a half. And in those 6 more months, a lesion popped up. Well, obviously, I'm not comfortable pulling you off your medication. But I've also had women come back 6 months later and their scan looks stable, Mabel. Everything's good. Drugs are working. We do their reconstruction and they get right back on the medication. So these are such unique and specialized conversations. And that's why, like, you got to love your team. You got to love each doctor in your team. And I think a lot of time the discussion and the conversations like come as an avalanche because you get the cancer and you're just like get it out, get it out.
Mhm.
And you kind of just go to where you're sent, right? But the reality is you can only pick your Avengers team. You can pick each superhero in your squad. And if you don't like somebody, you can find somebody else. There's no rule that it has to be the same group of people.
Yeah, I think that's great. I think especially for people listening in, who I think a lot of people do feel kind of like stuck or pigeonholed into the providers that they're matched with. And I think it's so important for, patients to understand like you've got choices. You don't have to go with the surgeon or oncologist assigned to you. You can, not shop around, but you can do your research and look around and talk to other
Yeah,
people.
absolutely. It's your life.
Yeah.
So
Yeah.
most of
A
us
lot.
shop around for a car we buy. You know what I mean? There's no reason you can't do that when it's someone taking care of your life.
Yeah, absolutely. One quick last question on the surge taking time off of medicine. Does it depend like does it vary per medication, like how much time you have to take off, or does it depend on the surgery and how extensive it is,
Most
or
of the
both?
time, I'm stopping things 2 weeks before, 2 weeks after. I have to say that's like my general rule, but the sort of correct answer would be yes, it's medication dependent and tumor type dependent and situation dependent and oncologist dependent.
Okay. Okay. Got it. That makes sense. Um, okay, great. Are there any like misconceptions or myths? Like we talked about metastatic, that's being a myth of like you shouldn't have a surgery across the board. That's a generalization. Is there anything else that's a misconception or myth that you've heard
You know,
in your
I
practice?
will have women, even on Instagram, that will like talk about their fourth, fifth, sixth, seventh, eighth implant revision. And I'm like, girl, get your flap. Like, the world has told you the implants are not meant for you. And they're like, no, it looks terrible. I can't deal with that recovery. And it was like, if you added up your last 8 recoveries, you really think cumulatively that's worse than a deep flap? Because I would disagree with that statement. So I would say, and I get especially frustrated when it's like influencers in the space that are sharing, and everyone should be empowered to share their story, but other people are watching and absorbing that information, right? And people start thinking like, must be normal to have 6, 7, 8 implant revisions in 5 years. No, not normal, not normal. And you may have things that go wrong with flaps too. I'm not saying flaps are perfect in the answer, but if one thing is not working for you and you keep getting that recurrent scar tissue, it keeps extruding, it keeps flipping, it keeps whatevering. That's not positive. Try the alternative. But yeah, I think that's one of the big misconceptions is just like people are so scared of flaps. And I can't even blame them because I know where it's coming from, right? When people post a bunch of negative experiences or scary results or scars they don't like, of course, the general public is going to be like, what is that operation? I don't want it. And it's important to remember that most women, not all, but most women that have truly recovered and moved on with their lives are not on the support groups and forums anymore, right? So they're not seeking that sort of friendship, kinship, mentorship guidance because they've closed that chapter and they've moved on. So you're getting a biased view of people who are still in the throes of it sharing their experience. So it's not an accurate representation. And I think it's important to ask your surgeon for before and afters, but I also think like if something keeps not working for you, think about the alternative. And I think deep flaps can look beautiful. I'm proud to show my results. And maybe not every result is as perfect. It depends on the starting point and the woman's health status and whether she gains weight or loses weight after and all of that. But I would say, gosh, overwhelmingly the clear majority of the time, I'm able to fix the problem they came in with. And that's what's important.
Curious for people listening in. So, when people think about what's covered by insurance and what's not, I'm assuming, that the removal of the breast tissue related to cancer is covered, but is a reconstruction surgery, is that something that's also covered by insurance if you have cancer?
It is, according to the Women's Health and Cancer Rights Act, this came out in the late 90s, 1998, I believe. It is federal mandate that any woman who is undergoing breast cancer surgery, even preventative, the associated reconstructions for their lifetime are covered. So even if you don't do it right away, but you decide to do it later, and all associated pathologies, including treatments like prostheses or additional treatments you might need for lymphedema, for example. Now, just because it's in federal mandate doesn't mean that insurance companies play nice in the sandbox. They can be difficult. And you also have to know whether your surgeon is in network or out of network. I am out of network with insurance, and I'm very open about that because I don't think adding financial like fog to things is helpful. It's already stressful. Be clear about what your fees are and what it's going to cost. Um, so some surgeons are in network, some are out of network. You want to make sure you know which one they are, and not just the surgeon, but the facility, the pathologist, anesthesia, all of that. Like in my paradigm, I'm the only out of network component. I work with all in network people otherwise. And a lot of insurance companies will allow for something called a gap exception or a letter of agreement in situations where you're seeking expertise that's not otherwise readily available to you in your in network selection. So I utilize that for probably 60 to 70% of my cases. They're not paying anything more than they would if they went to an in network surgeon because I'm fixing a mistake someone else made or their surgeon can't do what I can do. So it takes perseverance, it takes commitment. Insurance companies sure don't make it easy. I know they drive my office crazy, they drive me crazy, they drive my patients crazy, but you are entitled for coverage for these things.
Okay, and then maybe just to wrap up a little bit, the how do you talk to your patients about the mental aspect of like your body completely changing? Like obviously there's the cancer component, but
Yeah.
the physical change that you're going to experience
Ugh,
afterwards. What's
it's
some advice
so
you would give?
hard. It's so hard because A, I don't know, I didn't go through it. So I'm speaking as someone who's watched friends, family, and my patients go through it. And it's hard because there's a part of me where it's like easy to say, like, you're going to be fine. You're going to get through it. We're going to cure your cancer and all of that. But like, if all of my hair fell out and my eyebrows fell off, like, I would be devastated. So
Right.
it's hard. It's just hard. And there's so much already, like the weight gain and the skin changes and hair. And sometimes the texture of the hair never goes back the same. So it can be complicated. I think the best thing I say is like, don't feel bad about caring about it. That's what I always say. Like, there's no, some people are like, I don't mean to sound vain. I'm like, forget sounding vain. Like, girl, you're going through hell. Like, you should tell me everything you care about. Let's fix it. So it's okay to care about your skin. It's okay to really want to keep your hair. It's okay to get your eyebrows microbladed before you start chemo because you know it's going to affect your quality of life. Don't
Right.
feel bad about it. It's okay to think about your weight gain as it's associated, with your hormone therapies. It's okay to hate the side effects of your tamoxifen. Don't feel vain about it. Like, there's this sort of notion that you should be grateful that you survived is crap, right? Because women go through hell with this diagnosis. So my advice is always like, don't feel bad about it. Advocate for yourself. Self-care is best care. Like, do what you need to do. And I do give advice, like, get your eyebrows microbladed ahead of time if you think that's going to bother you. Things like cold capping or penguin caps can help a lot with hair retention. If you are dealing with weight gain, I always say, like, just get on your meds, like, start what we need to start. Let's check in at 6 weeks, 12 weeks, and then based like on similar intervals beyond. There are nutrition consultants, there are obesity medicine doctors, there are nutritionists. There's so many ways, like multimodal ways that you can affect weight gain and your health. Let's
Right.
get you on the meds first. Let's get you where we need to get you, like, treated. And while you're kind of, once you've gotten started on everything and we feel good about your cancer treatment, now let's rope in all these specialists. And sometimes that's a mental health provider, right? There's just the psychology of having your body ravaged like that and you have no control over it is severe. So ask for all the help. Don't feel bad about it. You deserve it.
Yes, I cannot agree more. I think there's, it's a really it's like a whole body approach, like mind and body and soul. And so I think it's, yes, it's about cancer, but there's also so much more to it. And so I think people should really feel empowered that all these other needs that they have are just as important as getting rid of the cancer.
Absolutely. I mean, I'll never forget. I've had multiple onset breast cancer, and one that died of metastatic breast cancer after it recurred and came back. And after her recurrence, I was at her oldest son's wedding, and she was like, "Psst, just come over here." And so I was like, "Yeah, what do you need? What's up?" She's like, "Can you fill in my eyebrows?" I was like, "Oh yeah, of course." Got out
Yeah.
my little Anastasia brow kit, filled in her eyebrows. And it was so crazy to me because she's an OB-GYN. She was like one of the first female OB-GYNs in her area, like graduated top of her class in med school, like a total gangster. Okay. This woman's a G. She's in India. She's amazing. And I'm thinking she must be so proud. She's marrying her oldest son off to this wonderful family and girl, and she's alive to be here. And
Right.
in her head, she's like, oh my God, my eyebrows, right? And so you just never know, like, what someone's thinking about. And like, no, she's probably not at this wedding being like, oh, I'm so lucky to be alive. And like, oh, she's probably like, I don't have hair. My eyebrows aren't here. I don't feel pretty. Like,
Yeah.
can we just get this over with? So it's like, I think about that all the time of like, you just don't know what someone's going through. And something as small as filling your eyebrows in can give you what you need to get you through your day.
All right, Dr. Srinivasa, thank you so much for joining us. This was super informative. And I think for people listening in, it's just so great to kind of like hear a consult and see, what they can expect when they go in for their own, or maybe they've had a consult and it was different from what you've presented
Yeah.
today. So I think that's amazing. Thank you so much for being here. If someone does want to get in touch with you, how can they reach out to you?
So Instagram, I'm pretty active on. My handle is Dr. Divya Srinivasa, DrDhivya Srinivasa. All one word, no dashes or dots. And then my website is theiabr.com, theiabr.com. There's a lot of actually really good information on that website. I think Instagram's like a fun amalgam of my personal life and my professional life. The website is really like a good source of information. I do have a lot of before and afters on the internet, and you can always reach out for a consultation. That's the one thing I say. I get a lot of messages of, here's my story, what can I do? And the reality is, social media is not really a great place to be a doctor, per se, specifically. So I always say, reach out, and I promise you it will be worth your time for me to really piece through your medical history, what's been done, what your goals are, and give you sort of an option or an array of options for what you can have done next.
Awesome. Thank you so much. Thanks so much for being here.
It's my pleasure.
Thanks for listening to The Other C Word, hosted by Bismolology. New episodes drop Mondays. Connect with me on socials at Bismolology, and let's all learn, grow, and inspire each other.